Are we recording now, Liz? Yeah, okay, great. Welcome everybody to the open board meeting of Ashford and St Peters. Today's meeting slightly different to normal. This is a meeting in public, not a public meeting as normal. So we won't be taking live questions, but we will take questions that have been submitted previously on the website. And just to say that for those of you who've been to previous board meetings, the reason this will be slightly different is we've had direction from NHS England Improvement regarding board meetings, and I shall read out. Trusts and CCGs should continue to hold board meetings, but streamline papers, focus agendas, and hold virtually. Well, we were already doing most of that, but so what we will do today is focus the meeting around a new style report that Suzanne's going to present, which is very much based on the risks, our strategic risks from our board assurance framework. And they have come up from each of our board subcommittees. So I'll be asking the NED chairs of those committees to just give a little bit of intro to Suzanne's report. And we're going to have a very focused meeting around questions around our board assurance framework. And Suzanne gives a summary in her paper. The other papers we will be taken as read, and we will only take urgent questions, obviously from any board member, on each of the papers as read. The aim being to take some of the pressure off the executives, because they're very, very busy, to say the least, at the moment, running an extremely busy hospital. And so if we can get through the board meeting in good time, we will do so. The only item on the agenda other than Suzanne's report that we will go through in detail will be the Ockenden report on maternity, because that is really very, very, the people will have seen in the papers, it's based on the Shrewsbury and Telford situation. People will also have read about East Kent and some of the issues they've had in their maternity. So it's very important that as a board, we obtain assurance that we are doing things correctly, that we are taking action in regard to what is recommended from the Ockenden report. So that's a bit long-winded, but I just wanted to put things in context. Welcome to the members of the public and governors who have joined the meeting. You're most welcome. And we'll now start the meeting proper. And I'll take any declarations of interest, please, in the proceedings from any of the board members. No, nothing further to declare. Okay. Thank you. Liz, have we got any apologies for this meeting?
I haven't received any apologies. I think everyone's on the meeting.
Okay, thank you. And just to say that if any executives need to go for any other reason, any other meetings, any urgent operational things, obviously you are welcome to drop off the meeting at any time, just so we get our priorities correct. Okay, so we'll now move on to the minutes. I'm not going to go through these page by page because it just takes ages. So anybody got any corrections on the minutes? Andrea?
Thanks, Andy. It's only the first page and it's my title, actually. I'm still down as interim chief nurse, but I was substantive.
Thank you.
Andrea.
That's all right, no problem.
You were and are substantive. Yeah, thank you.
We're not substantive indeed.
Any other corrections to the minutes? That's the minutes of the 26th of November. Okay, in which case I'll take those as agreed. Thank you. And we'll move on to the action log. Liz, what have we got on the action log that needs to look at this meeting? I think it's just the emergency planning, resilience and response that is for us to look at later on, and that's on the agenda. James, I think you're down to lead on that. We'll come to that in due course.
Yeah, that's right. Sorry, I've only just got to look at it. Yeah.
Okay, no, it's all right. Getting through it on virtually, getting to the right place is quite a challenge. And the balanced scorecard, yeah, that's a future meeting to look at. So there's no other things on the action log, which is good. We'll come to the chairman's report. I'm going to just take this as read. You'll have seen that it's a cut down version from my normal one. Just to say, of course, that I'm immensely grateful to the team ASPH, led by the executives and being led extremely well by the executives, for all the hard work that's going in. I've seen this for myself. I know how hard it is. I know how tough it is out there, that people are very tired, and inspiring the team to carry on is a huge, huge task. And I think the team have risen to the challenge really, really well. And I'm sure I speak on behalf of all the board to say thank you. And we do appreciate all the hard work that's going in. My report was written slightly before the vaccination hub opened. That of course is now up and running, and we'll obviously get a report on that later. And then I just thought, for a bit of light relief, I would put a few vignettes and photos in of Christmas. Seems ages ago now, doesn't it? But I've just popped those in just to say that really wellbeing activities carried on, over the Christmas period. And we're appreciating. So I'll stop at that point. If there are any any big questions on that, and then we'll. Good. Okay. All right. So the other point is this new report. It is the very first time that we've had it in this format. Any board members have any suggestions as to improvements, please let Sal have them offline. And I'm sure we can keep developing it, but personally I found this very helpful and focusing it. So Suzanne, I'm going to hand over to you, and we're just before I do, actually, just to say on the risk side, comments from the chairs of the three main committees that have met in this period, and just on the risk assurance they've done. So Jane, do you want to kick off?
Yes, thank you. The Quality Committee met last week, and I would concur with the summary that our Chief Executive has provided, in that the key risks we discussed actually are reflected very well in the summary in this report. We also, when we were thinking about our risks, we recognised that we might need to add some further detail to our board assurance framework around waiting lists and cancellations, because there's a quality aspect to that. So we did pick that up, and I know that is picked up in the performance aspect of this report. And we also considered Ockenden requirements, which we will be looking at further on in a full board paper. Our committee was a shortened committee which focused on the risks, and I think this report really does highlight the key areas that we recognised.
Okay, thank you, Jane. Merrick?
Yes, again, excellent summary. Thank you, Suzanne, in this new report format. We focus very much on, as already been covered by Jane, on the Ockenden report, and then the items which in many ways really have not changed in recent months, really around people and the performance on really the building backlog challenges that lie ahead for elective work. And in fact, we touched on that again this morning around how some of these statistics are being affected by the fact that, of course, we're not getting referrals from the GP practices, which is suppressing, I think, the level of pent-up demand that's in there. We spent quite a bit of time talking about risk and our risk scoring, where we will be having a look at that next month. But other than that, yes, I think we'll pick up the Ockenden report later, as Jane says. Thank you.
Thank you, Marek. Marcin, on people.
Thank you, Andy and Suzanne. I think it's an outstanding report. We also at People Committee focused our report, our meeting, all around risks. The 4 risks are correctly articulated in Suzanne's paper. We did think using the KPIs is an excellent way in which to visually validate your risk assessments, and indeed it did allow us to drop the first risk because we have been able to do quite a lot of workforce modeling, and we've improved our establishment, which you'll hear later on. So I think this is an accurate recognition of the risks and the issues, and I just echo, our staff are under immense pressure. And the morale of staff and just the ability, the resilience to carry on. So what the BAF does do that we debated quite a lot about, which is it looks at today and KPIs assessed today, but it is the future one needs to take to triangulate to come up with the appropriate risk assessment. Because whilst our numbers look good in terms of staff and our recruitment, what worries us is post this COVID, their exhaustion may lead to mass exodus. So one needs to always have in mind the future along with the current position. But excellent summation, and I commend it.
Thank you. There was due to be a strategic change committee today. That, in the interests of releasing executive time, Neil has agreed to cancel that, which I think is the right thing. Chris, I know that digital committee sits next week, so it's slightly out of thing, but anything from a risk side you want to bring to our attention at the moment?
I guess the main thing is, as Suzanne attended on Tuesday, we had a Surrey Safe Care, and I chaired that board. And there are, it's just in terms of the transformational programme, there are several areas that are in red. They were given 3 weeks to extend to complete. I think we've got assurance that they are getting there and progress is being made. We also looked through a number of options in terms of what that meant for the programme, and it was decided a further one called option 8 was agreed, which is really sort of carry on as we are, Suzanne, and do as best we can and make modifications further down the track as and when. But I guess the reality is it's very tight. There's a lot of people working very hard. There's subject matter experts who are pulled by COVID, so I think they're doing their best under very difficult circumstances.
Okay, thank you.
In terms of the risks, I don't think it's changed. It's high still, Andy, I guess is the point. Okay. We're on a knife edge there.
Okay. Neil, I just want to give you the opportunity. Is there anything you want to say about the collaboration piece from strategic change? Just checking. Neil, are you there? I think he's not there at the moment. Okay, in which case we'll go straight to Suzanne. Suzanne.
You're on mute, Suzanne.
Apologies. Thanks, Andy, and thank you to my non-executive colleagues for sort of commenting and providing additional assurance there. I mean, I'm not sure this. I mean, I would be really grateful for both non-executive and executive feedback on this report, and I'm not sure it's quite where I wanted it to get to, but I think it's the first iteration, and I think it's work in progress. So please do give feedback. The purpose was really to reflect the fact that we've kind of the approach that we've taken to governing the organisation is to have, and I think it's a good approach, is to have the strategic objectives and their plans and risks and mitigations overseen within those sub-board committees, and I think that's right. And of course, at the board, our task is to kind of stand back from what each of those individual areas of work do and take a more summative view. relatively easy to say, actually quite difficult to do in practice. So that's the bit I don't think I've quite got absolutely right yet. And I think I will work with the execs and with yourselves to keep working on that, because I think the point that Marcin makes about, and maybe this is what we need to do, is kind of what do we think is today's position, if you like, and what is the horizon piece? What does it look like for the future? And what actions and mitigations could we take today that are really more about the future than about responding to today? Nevertheless, and I won't go through each of the strategic objective risks. I think that the non-executive colleagues have done that and have confirmed that it represents their debate and discussion and their confidence. I think if you go to paragraph 2, figure 3, this was where, if you like, in terms of sort of coming to a view, other than the conversations we had, that was where I started to get a sense of, well, you know, within each of these strategic objectives, where are we carrying the most significant burden of risk? And you can see there it's clearly indicated, albeit at very high level, that people and quality of care are dominated by the high catastrophic risks. And whilst we've got significant mitigation around those, we haven't got those yet to the degree of agreed tolerability for those risks. So we are obviously tolerating them and we're continuing to refine our response, but I think that's where we see that risk emerging and possibly continuing to bring a challenge. I think section 3 is quite interesting, and again it's at a high level, but I think that was quite a helpful representation of the KPI performance, and I think again we can keep working on that, because where I'd like to get to is, in light of our assessment of the risk and the mitigation, how confident are we? Which direction is this going to go on? Is it continue to get worse, or is it going to be resolved over some sort of time horizon? So I think that's something I'd like to kind of keep working on. And then as you rightly said, we've got the BAF in Appendix 1. So that's the kind of presentational piece. The content, I suppose, is what's really important. And what I think we've kind of come to is a place which I think you've kind of already sort of drawn attention to. So clearly, operating the organisation as we are in the environment we're operating it in, there are material risks to the quality of care delivery today. And that is both directly born, as in what's happening in the hospital today, and indirectly born, you know, the things that we've referred to around the cessation largely of elective activity and diagnostic pathways other than very urgent and some cancer cases. So that's the quality of care risk, and within that you've got patient experience risks and so on, because clearly some of the operating environments that we're working within don't lend themselves to give the absolute best experience for patients, and waiting a very long time for the hospital for a diagnostic that you feel is important is a very poor experience. So I think we recognise that. And then I think the subsequent consequence of that is that the key mitigation to all of that is our amazing team, who are continuing to stretch themselves in every conceivable way, whether that be the hours that they're working, whether that be the way that they're working, adapting to new ways of working in a new environment. And then, of course, dealing with the emotional burden of providing care in these circumstances, which is very significant. Just caring for any member of the public when they are in a very poor physical and emotional state and separated from the people they love who would normally provide them with that support through a difficult time. We're filling that gap, and we're filling that gap with our colleagues at a degree of stretch, which I think is hitherto unknown to us, even in wave 1. So clearly the challenge we've had in this wave has been much greater, and it feels more sustained. So trying then to look forward in terms of what does that risk, how could that risk realise? I think the problem, I think Marcin pointed to it already. I think our teams are doing amazingly well sustaining today's activity and coping, and doing a great job and largely mitigating the risks that are described within the report. I think the risk therefore is sitting in their well-being, their resilience and their ability to sustain. And the potential therefore is that at some point we start to see such a degree of degradation in the team that they're unable to continue, and then we're in a position where we are unable to continue to deliver quality of care and meet the demands of our patients. And I think that is a real risk, not least at all forgetting the burden or marks, if you like, that will be left on all of the team when we do come to a position of being out of this scenario. It's a rather gloomy summation, because you kind of get to the point, well, what is the mitigation for that? And I'm just so grateful that we've got the vaccine. I think if we didn't have the vaccine, we would be sitting here today and saying, goodness me, well, how are we going to mitigate that risk? Because the patients will keep coming. We've got a very large waiting list in a number of specialties, which will be growing. Deep anxiety around that as well. So I think, testament to the team as they have responded in mobilising the vaccination hub. I think we've already seen and a huge benefit to the morale of the organisation, actually, both in those involved in giving the vaccine, but at those receiving it. And of course, we know that that will start to slow the pace of this viral load that we're seeing across the community. So that's the summative view, and so the key mitigation, if you like, strategically, is the deployment of the vaccine. And we continue to, and Louise and others can give detail around that if there are questions. Then the final part of my report is the more traditional piece. We've slimmed it down, but just wanted to kind of give a sense that there is still developmental, enabling and supportive work going on within the organisation to create a sense of order, which I think is very important. It's something that helps people balance and stay calm and focused. So we've picked out, the main effort I think has been a really important intervention, the health and wellbeing offer, just making the point that, Louise and the team and others are doing amazing work to generate a kind of agile, scalable approach to that. I think the media and communications team are absolutely working their socks off, and they are doing great work. I wouldn't say that we're completely all the way there in hand on heart. I know every member of Team ASPH gets every single message, but we are doing a whole range of activities, and David and Andrew have been key in that with James. We talk about the vaccine programme, and then of course, there's the work looking to the future that is underway around the new building infrastructure and the new emergency and assessment building, and obviously Surrey Safe Care, which Chris points to that's carrying significant risk, both in terms of its delivery, engagement with the teams when they're trying to do a lot of other activities, and the timeline, which is crucial. And of course, then there's a financial risk as well. So, none of the things that we're doing at the moment are without risk. But I hope that piece of the report just gives a sense of that whilst we're all very busy dealing with today, there is activity underway and ongoing that's supportive and also looking to the future. And I'm happy to take any questions or invite any of my executive colleagues to comment on their particular portfolio contributions.
Thank you, Suzanne. I've just got a couple of comments and questions of my own. I'll just kick off. I think I was on the public meeting for Surrey Heartlands yesterday, and the Chief Executive of Royal Surrey made the point very strongly that when we eventually start coming out of the pandemic, and we then start getting direction from the centre as to the restoration of services, that we build in sufficient time for leave. And you know, it comes back to the people thing, and I just wanted you to know that you have, you know, the full board support to align with Royal Surrey, and I'm sure the rest of Surrey Heartlands as well, to do this, because if we go straight from this to hugely stringent targets around recovery without giving substantial time for people to take a bit of time out, we will manifest the risk that you've described in terms of people just saying, I've had enough. And you know, you might get a lot of people perhaps who are near retirement just calling it in early. So that was just a comment really that I'm sure all my board colleagues would agree with, and it was certainly brought up and brought to the attention of Region on yesterday's call. They heard it. Whether that will manifest itself in doing that, we will wait and see. I think the second thing also regards to our people is the Health and Wellbeing Centre. So I think the board needs to understand where we are on that health. We've promised this a long time. It's something that we absolutely need to do anything to mitigate. So it'd be good to have that. And the third point, I think, is just a comment again on Collaborate, that Lord Andrew Morse and myself had a catch up last week, I think it was, and some great work going on in Northwest Surrey on the collaboration. This is just for board members in the various towns in Weybridge, in Woking, and starting in Staines and Sunbury and coming to Addlestone soon. That actually there's some really good work in terms of working with the community. For example, you know, where is our maternity hub going to be in Woking, etc., etc. So despite all the pandemic, despite everything else, there's a lot. I'm just going to pause. And there's an awful lot going on the Collaborate piece as well. So the one question around the Health and Wellbeing Centre, Suzanne, the others were just comment.
Yeah, no, thank you for that, Andy. So I'll come to Louise. Louise and Tom have been working on the design and the procurement for the Wellbeing Hub, and I think we've got a timeline and a proposition. So Louise, do you want to update with Tom?
Yeah, happy to do so. I mean, and before I do, I guess it's important to say that not all of our wellbeing is delivered through a wellbeing centre. And so just to remind the board of the extensive health and wellbeing interventions that have been in place over the course of the pandemic and ever increasing, including quite a significant change to the retail catering outlet. So some significant improvements that we've given to people in terms of access to food and being able to do that in the most flexible way possible, extending the seating arrangements in the postgrad so that people can go and find a space to have a break, and can hopefully do that in a socially distanced way. At the moment we have Project Wingman, so we've taken over the Education Centre at Ashford and the Lecture Theatre at St Peter's to give people first-class cabin crew experience when they get 5 minutes to go and have a bit of downtime. We've extended the external outdoor space. So again, that being outdoors is really important at this time. And so extending the space outside for people to go and have a break. And the facilities in relation to that, a lot of staff have volunteered to help make that look a nice environment. So the green space outside is important. And by the middle of February, we should hopefully have a heated canopy outside so that actually people can use that space even in bad weather. The space in the, and I can't think of a better way of saying it than the undercroft, but in the basement is coming along in terms of progress. We are hoping that we will have the changing facilities completed by the end of March. And did a presentation to execs this week just so they had some assurance around the materials that we're using and the look and feel of the space. So it isn't something that that is just very basic, but is something that is going to be a really nice space for people to use in terms of both the changing facilities and the bigger wellbeing centre. The wellbeing centre itself, we are aiming to have handed over to us in a space to then be able to fit out by April. Obviously, some of this is depending on access to materials and Brexit, and some delays have occurred through that process, but we are working through it. We've got architect drawings. We've been engaging with colleagues in terms of what it would look like inside. And so again, Suzanne has given me really clear direction that she doesn't want, kind of basic plastic chairs. She wants something that is going to be a space that people will want to go to, and that will be able to go and sort of play table tennis, sit down in a comfy sofa, etc. So we are well on the way with that work. Obviously, the feel of it, again, we want to try and make it feel like we've got the environment from outside inside. So the architects are giving us advice about how we do that in a way that is fit for purpose. So I think quite a lot of progress, and hopefully Tom and the exec colleagues can give assurance that we are kind of in train and are expecting for that to be delivered in spring, early summer.
Thank you, Louise, and thank you also for drawing our attention to the wider health and wellbeing piece. And I know that your team in particular have been doing sterling efforts really to reach people. So thank you to you and your team for that. I'm going to take Tom next because it'll be.
Thanks, Andy. Yeah, it's just to follow on really from what Louise has said, all of which I agree with, and the timescales are as she's described. It's just to mention really that quite a lot of what we're able to do has been supported by charitable donations, it's just important, I think, to record that those donations are being used directly for staff wellbeing, not just in the midst of this pandemic, but there'll be benefits for staff that will then be there in perpetuity. So it's just, I think it's important to make that point and to thank those people who have donated.
Thank you, Tom. So I'll take Andrea next.
Thanks, Andy. I just wanted to comment around our particular area of quality of care, actually, within Suzanne's paper, and just to give just some assurance, really. I think that the infections, the pressure damage, and the patient experience as the key areas that are sticking out are indicative, really, of the COVID situation that's placed on those particular areas. But just to show some improvement, actually, around the infections, although some of those areas we haven't been able to meet our target in light of our North Star objective, actually compared to this time last year, there is an improvement, which is something actually that is quite significant considering the challenges that we have had, and it was just to highlight that we did have a regional NHS England improvement visit, an assurance visit looking at our IPC practices and our setup, and actually we got a really good result from that, and actually the findings for that were excellent, and exemplar practice has been highlighted, and I think that's testament again to the strong focus that we've had around infection prevention control within the trust, and the executive leadership around that as well, that's been collaborative in its approach, and I think that's definitely filtered down. And from a national perspective, I was on a webinar yesterday, and they did say for those organisations that are doing particularly well with their healthcare acquired infections in relation to COVID, those trusts have shown to have very good, strong leadership, collective leadership around IPC practice. So it's just to bring those particular aspects out, really. I think it's just unfortunately indicative of the situation that COVID has placed on us.
Thank you.
And the well-being, I'll just make a note, because I do, from a nursing and midwifery perspective, I think both physically and mentally that cohort are exhausted at the moment. I've got various forums that I'm involved with them, and in particular they're quite flat, and but thankfully, I think we have started to turn a corner with the numbers, and I think, and with the vaccinations, hopefully that mood will be lifted. But I think that what we do in the next couple of weeks, really, around health and wellbeing, will be crucial.
Thank
how
you.
we pop out of it. Thanks.
I'll come to the non-execs in a second, but David, you've had your hand up for a while.
Yeah, so I was just going to say that I really like this report, Suzanne, and I think it follows on from the People's Report. I think it does really coalesce what we're trying to solve in the organisation, where the issues are, and actually also gives us a view across the divisions and across the whole organisation. So I think it works. There's a bit more to do, but I think that's really good. And I agree with everyone that says is the biggest pressure is on our staff in the organisation, who are doing an absolutely magnificent job. But I think we also mustn't forget we have a job to do as well, and it's really important that we do make sure we're focusing our staff's precious resource, which is their capacity, in exactly the right places. And I think looking at this report, I think the main effort slide is an absolutely fantastic slide. And I suppose what it made me look at is, are we doing enough? Are we doing enough things in that particular slide? So that's what it made me think of, because I think there are some things that we're doing in the organisation. We are making some capacity in some areas, but we still have got a slow flow in lots of areas into the organisation, through the organisation, and out of the organisation. And that adds to the burden to the staff, but it also has a big quality issue. So what it made me think is that we've just got to, we've got to manage the organisation. We have got to use this really precious workforce resource in the right way. And it just made me think that maybe we should pay a bit more attention in that area. So I really like the report, because it did bring that home to me.
Thank you, David. I'm going to go to Jane now.
Thank you. Yeah, I agree. I found the report quite helpful because I think it really summarises exactly where we are at the moment. And obviously, it probably does need some work, but I think it's an excellent start. I was going to pick up the point that Andrea's already raised around our NHSI England visit, and that was really positive. So although we're disappointed that we're not doing as well on our infection prevention as we would hope, I think we are doing a really good job in very difficult circumstances, and I think obviously we'll continue to aim to improve. But with regard to pressure ulcers, I think, as Andrew alluded, just to make it clear for the board, that there is quite a lot of evidence from other areas that COVID does actually mean that people are more at risk of developing deep tissue injuries and pressure ulcers, and I think the reasons for that are very complex. But I think it is a recognised complication, and I think other areas are also finding that is quite a challenge. So it's just really for the board to be aware. My question is that I was on the Swartz round yesterday, and we were listening, and it was very moving to people telling, reflecting on their experiences with COVID. And one of the things I think that I had said, or people need to look after themselves, actually was pushed back as actually some people aren't able to do that now. They're so tired that actually it's a collective responsibility for us to recognise when our colleagues are struggling and to pick them up. Because actually when you are really down in the dumps and you're really down in the trenches, you can't actually find your way out. And so it's actually just a plea for us all just to be kind to each other, really. And that's across the board, to the colleagues and to the wonderful staff that are delivering the service, because sometimes you don't recognise you need help because you're too low. So I think that's really important, because that came through quite clearly, that putting the responsibility on people that are already tired to seek the help you want, seek the help you want, it may not be possible. That was just to make that clear, really.
Thank you. And just to be absolutely clear, all the non-executives, we had a meeting this morning, are absolutely available if executive colleagues wish to just let off steam or just have a chat, Suzanne already uses me in that respect. Just to kind of talk things through. All the non-executives are available to executive colleagues, and I would urge you to use that resource, not to solve problems, but just to kind of, if you want to just, let go on something. So we are all available, and certainly 24/7 as needed, I'm sure. The other point I'd like to make, and it just builds on that, is we are getting, again, this support from the community, which has been mentioned. And, I've just pulled up my Instagram here, and there's two organisations in particular. The Nourish Our Nurses has sprung back to life, and that's wonderful. And also the Help Your NHS one as well, which is urging donations, and I know is looking at scrubs and things at the moment. Those are only two, and I know we're getting lots of individuals as well supporting, and of course volunteers on the vaccination centre. So there's a huge amount, and I just want to record on behalf of the board our sincere thanks to individuals and these organisations for their help and support, which does really help, and it's great to see that, you know, out on social media. You know, I'm just reading the latest from Help Your NHS. Donations have gone quiet. Please keep donating, and with a little heart and Ashford and St Peters in the middle. So that's very recent. So there we go. James, you had your hand up at one point. Is there anything you'd like to say?
Yeah, I took it down only because I thought most of my points had sort of been raised by colleagues, but I think there, you know, we are very, you know, we have, as execs, we've all discussed the need to be mindful around restoration comes, and the enormous pressure that was on us last time around restoration, right? And so we've sort of talked about that quite a lot, and there's a number of strategies that we can do that would look at other ways of mitigating the pressure on our colleagues, and to give colleagues time off, and we all appreciate we really need to do that. And I think that's an approach that we're very mindful of building in from the start. In fact, Suzanne and I and Simon have been having a discussion this morning just on that subject. So we're mindful of that, and also the amount of work that's going on to enable this stuff. So we've built a pop-up ITU, we've made adaptations to ED, we've got work happening at Ashford to open a Elliot, which is part of our North Star objective to get our elective work over to that site, which means moving bariatrics. We've got work on the way over there to make adaptations to space to put pre-op assessment over there, which is another part of the North Star objective, to keep that on the elective site. So, and those examples just carry on. So there is just so much work coming together, aligned around this North Star, this main effort, that it's it's just a lot behind the surface, I think, like under the surface around mobilising what we currently are.
I think that's a great point, James, and it does emphasise the team nature, doesn't it? Because people, colleagues in estates have got a big part to play in this. And I'm minded that, the deal we've done at Ashford around parking with Tesco's, because we know that parking was an issue at Ashford as a result of pushing a lot more services over there, and we've now got that temporary deal with Tesco's, which again, mitigates that for our staff. So it's a huge team effort, and every single part of the organisation is involved. Chris,
I just wanted to make the point really that in terms of the report, I actually think it's taken it to a new level. I find it incredibly insightful, to get that overview and from Suzanne into all aspects of the business and the perspective on the BAF, and I think it's incredibly useful. So although it's work in progress, I think we are very fortunate in having a CEO who really gets stuck into every part of the business. So thanks, Suzanne, for that. I think it's just an accolade to us to have someone of your capability and your conscientiousness, and that's reflected very much in the report. So I'm grateful for that, and I'm sure my other colleagues are as well. So thank you.
Thank you, Chris.
Standing on the shoulders of my team, Chris. They're the ones that do all the amazing work. Andy, I wanted to just sort of check in really with Louise, because I think it would be really helpful if Louise gave an update on the vaccine hub, but I didn't know whether you wanted to do it here or in the people committee feedback.
I think it'd be useful here, actually, because our theme has very much been supporting our staff, hasn't it?
Yeah,
today.
Yeah, and I think it's been, there's some detail behind, and just its progress has just been phenomenal, really. So, and Louise is the SRO for the programme.
Yeah, thanks, Suzanne. So obviously, we only became a vaccination hub relatively recently. So in December and early January, our vaccination attention was very much around trying to leverage as many vaccinations for our colleagues as possible within our provider organisations. And so, wanted to record our thanks to NICS Federation, who opened their doors to enable some of our higher risk workers to have their vaccines quite early, as well as obviously Royal Surrey, who again opened up slots on a regular basis so that our staff could start the vaccination process. We were then delighted that our vaccination hub opened, and it opened last Thursday. It feels like a long time ago, but actually it was only a week ago. So actually the statistics that I'm going to tell you now are quite amazing. So we opened last Thursday and we have vaccinated 3,577 people as of last night in our vaccination hub, of which 1,600 approximately are our own staff, and nearly 1,900 are members of the wider health and social care teams in Surrey Heartlands. So that, is just phenomenal to have been able to achieve that in 8 days. The vaccination hub has run over the full 7 days of the week, but we're very much dependent on supply of vaccine, of course, and the logistics around ordering, delivery, and then obviously with the Pfizer vaccine, which is the one that we're using, the storage issues mean that this is a kind of a logistical headache for us on a daily basis in terms of how we plan going forward. So we wouldn't have been able to do this without the amazing support of a number of people in the organisation. And it is useful just to do a bit of name checking of those, Suzanne, because the hours and the energy that people have put into this is incredible. So we were really fortunate to have one of James's ADOs who stepped up and said that he'd like to be involved. Paul Bostock, he's the Associate Director of Operations for Women's Health and Peds. And Paul has led on both the staff and patient testing programme, and then moved on to leading on to the vaccination programme. And having somebody of his operational calibre has been essential in terms of us being able to understand all of the factors that go into setting up a hub like this. Hannah Spencer, who is the Divisional Chief Nurse, again for Women's Health and Paediatrics, has stepped into the role of being the lead clinician for the implementation of the hub. So Hannah has waded through treacle of all of the training requirements for the colleagues that need to go through in order to be qualified to work in the hub, and has spent significant amount of time with my team recruiting people to work in the many different roles that we've got. She's obviously been supported by Zach, who's familiar to you all, our Deputy Medical Director, and Zach has helped particularly around mobilisation of the doctors, because this is a team effort. You do need both doctors, people to vaccinate, registered professionals to vaccinate, as well as the administrative and logistical staff to run the centre. So, I mean, it has been a massive team effort, and I've been so proud to be a part of it. Sadly, because I'm at home, I haven't been able to go to the vaccination centre, so I'm relying on colleagues to give me feedback about what a feel good they get from going into that centre, and partly because of the sort of diverse nature of the people that we've been able to recruit into the vaccination centre. So since December, we've recruited 178 colleagues. So that's, in the last 2 months, of which, well, less than 2 months really, of which 120 of them have come from the airline industry, which again is a great example of us being able to reach out to our local community, to industries that have been significantly affected by COVID, and offer them opportunities for employment. But actually what they bring is a level of professionalism and customer service skills that's quite different to some of the more traditional routes of recruitment that we have. And that's really been commented on by a number of colleagues. One of our orthopaedic surgeons who's done a couple of shifts in the vaccination hub said that, you know, he has thoroughly enjoyed, and it's been, you know, one of the most enjoyable experiences of his career, working with a range of different people in a centre where your clients are all very grateful and very happy, and in a place that the logistics and the flow through is second to none. So I think, you know, thank you to everybody that's been involved in that. And long may it continue.
Thank you for that, Louise. And just from my own experience of being over there a couple of times now, you know, the people giving willingly of their time, you know, some of the doctors on their days off, and finding immense satisfaction actually in doing something completely different from what they normally do. And also the volunteers. I mean, the volunteers are fabulous. And also the unsung ones upstairs in the finance area, you know, doing all the data entry and everything else, led, I think, by June. You know, they're just getting their heads down and just getting on with it and, you know, doing their bit. And again, you know, it's the admin side, it's the meet and greet side, it's everything is just working fantastically. And I just, and it's interesting, I put a tweet out probably over the weekend after I visited there on Friday, and it's probably one of my most retweeted tweets, you know, with a few photos and likes, you know, that, and, you know, we wondered what the result of that tweet would be, but actually it's been 100% positive on social media.
That's good.
So, you know, that was really good. And yes, we'll absolutely, we've agreed already in closed board that we would send a board thank you wrapped around Suzanne's video, which she's done yesterday, so that we can recognise that. At the same time, of course, we need to make sure that we don't make too much of a fuss of them whilst loads of other people are still in the trenches kind of working. Because the experience from elsewhere is, oh, you know, you're giving lots of airtime to the vaccination, and what about us, you know, who are carrying on with our everyday. So it's a balance, but I think at the moment, celebrate this success, absolutely. And let's hope the vaccine keeps flowing. Okay, I think I'll probably want to move us on unless there are any more questions on this area. I think it's been a really fruitful discussion based on risk. Neil, you've got your hand up.
It was, sorry, just one quick observation. As I was listening to Louise, I was struck by the fact that what happens inside our hospital is a good, I think, predictor of the future, because actually what the teams demonstrated with this report, and Louise's was the kind of capturing of some of it, was the collaboration that's going on inside to cope with the crisis is a function of it takes a team strategy culture. And I think if we were having strategic change this afternoon, and we'll come back to this when we next do, I think what we're learning about ourselves and what we're learning about the system is going to accelerate that collaboration across the healthcare system around us. We talked about this after wave one. It seems to me that wave two, which has been so much more dramatic, actually it's wave three, depending on how you choose to interpret the way the government's handled the crisis, wave three, shall we say, I think it's a real accelerator of change across the system. And I think that's actually the focus we'll need to put on it when we next meet at strategic change. I echo what you've said, Andy. I think we can be proud of this team, while still remaining very concerned and worried about the impact on the staff working in these conditions.
Yeah, thank you, Neil. Very helpful. Okay, so we're going to move on, and as I say, with the exception of the Ockenden report, we will be taking as read, only taking urgent questions from this. So the quality report, I'm just going to go to Jane first, just to say anything that you want us to note.
Okay, thank you. I won't, most of the key risks we've already discussed in the Chief Executive report, so I'm not going to labour those, and I assume everyone's read the report. Just a couple of things to highlight around complaints. Sadly, our performance wasn't quite so good in the last month, and that was due to staffing issues, and so that's something we're going to focus on. And we also recognise that we're starting to get some information from Viewpoint on patient experience, and the committee recognised that this was vital to really get a sort of heat sense about how patients are feeling coming through the service at the moment. And so that's something we're going to try and focus on a bit more at the next committee as part of the quality report. And as part of Ockenden, you will see that we've got a later report on that, but just to assure the board that we had the full assurance document, the assessment, that it was a requirement against the Ockenden report at the committee, which you haven't got a copy of, but it's quite a lengthy document. And we also received the full copy of a serious incident report, which is a requirement of Ockenden at the main quality committee for the committee to review. This was an incident that had been actually completed. The investigation had been completed in December. So just for the board to be assured that we did spend quite some time looking at that. But I will talk more about Ockenden later.
Okay. Just before I come to Andrea, Keith.
Thank you. Just to triangulate with the earlier discussion we've had around the benefit of colleagues coming from, for example, the airline industry with customer service experience, some opportunities for more learnings and possibly even some recruitment into handling complaints, the managing patient experience and so forth. So there are skill sets that we probably haven't that don't naturally necessarily come through a health career, and it may be there's this one of the side benefits of this will be actually as I say, a cross fertilization of that input.
Okay, thank you, Keith. That's good input. David?
I was just going to say, because I think that is great input, Keith, but I think the thing that we're finding with this group of individuals who come in is that they're very suitable to roles which were previously just healthcare worker roles. They've got really good people skills, really good communication skills, and that is the fundamental and most important thing with looking after people. So I think it is not in back office stuff, but I think we need to get them in the clinical workforce as well.
Okay, thank you. Andrea, any points you want to?
Yeah, I mean, I think as Jane said, we sort of brought out the main sort of issues which are reflected, I think, in the quality report in Suzanne's report, just to add a little bit more clarification with regards to pressure damage, because I know that will be a concern. And just to follow on from Jane's comment on this, it's we have seen an increase in deep tissue injuries, which we did see in the first wave, and it is, as Jane said, it's correlated with particularly within COVID patients and particularly end of life, actually, where we're seeing a bruising happening on the skin, and not necessarily around in pressure points, actually. Some of them have developed on shins, for instance, which then deteriorate into a deep tissue injury, and it's down to the hypoxia, we think, or the lack of oxygen to that skin that again that we're seeing in that's manifesting in COVID patients. So we're not the only trust to be seeing this. It's actually regionally and nationally a problem. Lots of research is going into it and investigations going into it as well, and hopefully as that evolves we'll be able to report a bit better on that going forward at the committee and board on that. But it was just to illustrate why we've seen a spike.
Thank you. So can we, any other urgent questions on the quality report? Thank you for that. Jane, we've got the quality of care November minutes there. Is there anything you wanted to draw our attention to, or we've all read them?
Yeah, no, I'll take them as read. The only thing, just to note, that we did see a number of annual reports at that committee, which was quite helpful. We've and they were all accepted. We, at the meeting that was last week, it was a smaller meeting. It was because we were focusing on the key risks, as we've discussed. So the divisional reports had actually been written, so they were received, but we didn't actually require the divisional representatives to attend because they were busy operationally, and that was agreed in light of the lighter governance framework that has come from NHS England. We had a revised performance report which was very well received, which James and I had discussed, and we're going to continue to refine. So that was really focusing very much on the quality risks related to performance. And I think we found that the committee members found that very helpful. So we're going to continue to refine that. And that was a really positive thing. And I think to be able to focus on that in these difficult times just shows the key focus that this organisation has on quality. And I was really pleased to work with James on that, because obviously performance affects quality. There is absolutely no doubt about it, and patient experience. So it's really good that we're working on that together. And his team have done an excellent job in our first draft of that, which came to the committee. Just to say that we will be talking about Ockenden and learning from mortality. I just wanted to touch on that, but we're going to be picking that up in the next report. So thank you.
Okay. Okay, so that's a good thing, I think, to move on to Ockenden, just to set the context for the public who will be watching this. The Ockenden report is the report into the issues that Shrewsbury and Telford have had. And lots of recommendations have come out of there, and NHS England sent out a very urgent letter asking us to sign up to these 7, I think it was, things that we had to do straight away. So there was a letter that went back in December. We now have to make another representation for 15th of February, I think it is, mid-February. I'm going to leave the team to this, but just to say this. Clearly, safety in maternity is a national issue, and it's been brought more to the fore by this report. And you know, this is being taken very seriously in this trust, and it's being looked at obviously at all levels, executive level, the Quality of Care Committee, and of course we're getting the overview here at board. So Jane, I'm going to ask you to lead off on this.
Thank you. Yes, as Andy has described, there has been some concerns nationally around maternity services, and so this independent review by Donna Ockenden came out in December. There have also been some concerns by CQC around some maternity services being found to be inadequate. So there are some governance concerns around ward to board governance, around leadership, around safe delivery of care, particularly around the management of serious incidents and their visibility at a senior board level, which is why that recommendation has come through. Following the letter, we had 7 immediate and necessary actions, and a letter was returned which indicated that the trust was compliant with most of those, and there were just a few that were partially, but we have clear plans in place to make sure that those immediately necessary actions will be completed very quickly. So I think we can assure ourselves that those have been addressed. We had an assurance document that came to the committee, as I said, and one of the key issues is around workforce. And there is a requirement to look at being birth rate compliant, which is a national requirement, and also to look at some key governance roles. So this is leadership roles that we might need to make sure that some key areas around the review of certain aspects of maternity care have the necessary senior leadership and oversight to make sure that they are looked at within the maternity services, but then they are escalated up to the Quality Committee and then to board appropriately. And part of that was reviewed at Modern Healthcare. So I will be handing over to the chair of Modern Healthcare in a moment, just so that we can describe the financial implications for that and the decision of Modern Healthcare in respect of the recruitment, because there is a burden for us financially, but we have a very low risk when it comes to any consideration around safety. And so we are very clear as a trust that obviously where it comes to requirement to make sure that we are compliant with the Ockenden report, then that is something that we will obviously work to make sure and ensure we are. From a board reporting point of view, we are required to report monthly with a clear data set, which will be reported to the Quality Committee on a bi-monthly basis. But there are quality safety meetings that Andrea, myself and the head of midwifery attend on a monthly basis, and we will provide a written report from that, so that in between the Quality Committee and the board, the chairman will receive a written record of that quality safety meeting, so that he can be, and I can assure him that any actions are being taken and there are any risks that I will highlight to him, just so the board is aware of that. I'm going to hand over now to Eric, who's going to talk about the financial considerations that went to modern healthcare with regard to the workforce.
Thank you. So the cost of this, when we get to full complement, is 1.2 million. The question arises, of course, is how do we fund it? Actually, funding in a post-COVID world across the whole NHS is not yet set and determined, but simply if you reference back to our prior operating costs, this would be a 1.2 million pounds additional funding. As James clearly said, our appetite for risk around patient care and harms is extremely low, and that's compensated by our tolerance of relatively high risk, commercial risk, to address that clinical risk. And in that regard, Modern Healthcare Committee has approved this expenditure. As we look forward into a time when this will be funded in an unclear funding regime, I think probably the thing to note is that where we used to be funded on pay by results, of course, we don't expect the number of expectant mothers and births to increase, and therefore, if we were under a pay by results, our revenue wouldn't change in respect of these additional costs. But as I say, the funding approach looking forward across the whole piece is yet to be determined.
Thank you, Merrick. So Modern Healthcare is recommending to the board that we sign this off from a financial point of view, and the Quality of Care Committee is recommending from a quality point of view. So Andrea, anything you want to bring to our attention?
The only thing I'd like to add actually is that I think it's really important to stress that we have been on a maternity transformation journey actually, and there's been a lot of good work that's been undertaken, which has included a lot of the recommendations actually within this Ockenden report. And so we have made some leeway on that, particularly around the workforce as well, and strengthening the governance processes. So I think it's just important to note that this isn't sort of a new issues that we've suddenly had to deal with. We've recognised these before, and it's part of our transformation journey that we've been on.
Yes, a great point, Andrea, because this didn't take us by surprise, did it? Mm-hmm. That was, the letter that went back in December showing we were compliant in so many of the areas, and at least had plans for the others that sort of demonstrated that. David.
I think the only other thing to add is that these kind of initiatives are exactly the right thing to do, but what it does start signposting is whether there needs to be a bigger strategic direction in systems with these kind of services, and those are going to be difficult conversations, but that needs to start if we are going to maintain the quality. And we have started that in certain areas. Maternity is a little bit of an area where these kind of discussions don't take place, but it is really needed now. And I think we need to use the influence that we can to say we need to start talking about these things.
Yeah, thank you, David. And the other point I think to make is that we have, haven't we, Suzanne, alerted the system to the cost of this, and that, and that we would need to be covered for the cost of this. Whether they will agree is a different matter, but we have alerted them, haven't we?
No, absolutely. I mean, well before we received a letter about the Ockenden report, we've been in a debate with our system colleagues, both about the configuration of service for Surrey Heartlands and what makes sense, both in terms of patient demand and flow, but also in terms of ensuring that you've got the critical mass of expertise that you need, and the appropriate level of resourcing. So I think the conversation has been underway. I mean, David points to the fact that it's always a difficult conversation when you get into a debate with other parts of the system around maternity provision. But no doubt some of this, the sort of pace that's come on it as a result of Ockenden, which is, I suspect, in many ways, it feels very directed. And, for members of the public joining us today, they might be thinking, well, that, everybody who's got a maternity quality issue gets a letter about the Ockenden piece. I think if anything, this is about reducing variability in our systems at a national level, and setting a standard, if you like, for the way about, you know, how you deliver good maternity care. So, which I think in you know, at a strategic level, I can see the sort of imperative there, and that feels like the right thing to do. At the same time, it will help us bring pace to the conversations we're having at a system level. You know, with regards to the finances, I think, you know, that fundamentally we're operating as a system system financial model, and so the system, we will have to work together to work out how to resolve what for us and the other trusts is a cost pressure, and the system board will have to make some, you know, probably some difficult decisions about how we do sustain that. One of the answers to their difficult problem, of course, goes back to the reconfiguration piece around how would you stratify the patient caseload and how would you reorganise services in a way that makes all of that achievable. But that will take some time, no doubt.
Absolutely. Chris.
Just a word of caution, really. I mean, what we talked about in the quality report, and Merrick's mentioned the financial dependency, and that's good that we are getting the funding, but we're sort of not out of the swamp. It does require new workforce and new skills. It does require IT support, dedicated support, you know, and it's not necessarily in place yet. So I guess it was something I mentioned to Gemma. I really like the enthusiasm and the fact that we have the plans, but they are still of intent. They're not yet landed, and I think we need to make sure that we keep on top of this to make sure that we do get the right resource and the right support that's needed to implement it.
Yeah, thank you, Chris. Yeah, good point. Merrick.
Sorry, just to correct you, Chris, we haven't got the funding. We're going forward unfunded with a view to try and get the funding.
Yeah, yeah, it's for this board now to agree that we will go ahead with this. I think, you know, it would be heroic of us not to, frankly. So, you know, this is something we have to do. It's our low risk tolerance of quality and safety, absolutely in the area. And, you know, I don't think we have a choice from a patient care point of view or our own risk appetite point of view. So anybody else want questions on this? Chris, you've still got your hand up. Is that another point, or is it an old hand? Okay. All right. So and therefore say, are we therefore happy that we go ahead with this, that we let the team obviously go back with their letter that is due in mid-February? Andrea, I'm assuming there's no issue with that second letter that we need to be aware of? No.
No, Andy, we're on course, absolutely.
Okay, and that we are, perhaps comfortable is not the right word, but we are content that we go ahead and make this additional funding, have this additional funding pressure. And we know that, as Suzanne rightly says, it's a system pressure because all the trusts have got exactly the same issue, which adds up to a system issue. So yes, I'm going to take that as assurance unless anybody says so. So thank you. So thank you, Andrea. Thank you, Jane and Merrick, for the work that's gone in prior to this at committees. A good example, I think, of the committee structure working properly and bringing the right things to board. Okay, next we've got the adult ward safe staffing review for October, and this is for assurance. Andrea, we've read this, obviously. What would you like to bring to our attention?
Well, I mean, it's assurance. When we're required to complete this twice a year, actually, to do an establishment review using the acute interdependency audit. I mean, we were meant to do it in March last year, but because obviously the first wave, that was delayed to September. It's just due to the situation, really. We're due to do it again in April. But this report really gives the findings from the September audit, and really just the key things to say is the staffing levels were sufficient, really, from that audit. There have been uplifts in templates, and that's due to Chestnut Ward coming online, increasing some of the staffing at the Bradley unit over at Woking, and our escalation areas that we've been using of Wordsworth and Heron, and also the one-to-one specialing as well. We've brought that into the establishments because that was being done very much on an ad hoc basis. So it's just standardising that approach. So really, they're the key things to be honest, Andy, from it. Yeah.
It does strike me that, you know, the old adage of eaten bread is soon forgotten, but bringing chestnut on was actually a big issue, wasn't it? And it's something that, you know, from an estate's point of view, from a staffing point of view, and we've kind of almost forgotten that now because it's old news, but actually it's another great achievement.
It was. Yes, at quick pace. Right.
So, Marcine.
Just to say, Andy, in line with how you dealt with Ockenden, this also came to the People Committee first, and the People Committee approved it and recommended it to the board.
Thank you, Marcine, and thank you. I neglected to come to you then. Sorry. Okay, so do we have to approve this, Andrea? Is this an approval or?
It was a yes. It's proven.
Okay.
Yes. Yeah.
Okay, it was down as assurance, but it's
it was down as assurance. I just noted that actually. Yes.
Yeah. So if we next time can please make sure this comes for approval. But I'll take that as approved. Yes, as People Committee, thank you for your work on that first. That's good. So we'll move on now to David, learning from mortality reviews.
Yeah, so we discussed this at the Quality Committee as well. I suppose the first thing to point out is this is from the second quarter. So this does seem years ago, actually, is up to the end of September. And I suppose it's interesting in reviewing this report when we've just gone through the 100,000 deaths in the country from COVID, which is a terrible milestone. I suppose the important thing just to pull out of this report is that the issues what we're struggling on is the initial screening view. Now this is when we're coming out of wave 1 and wave 2, and that's still an issue. The medical examiner role has proved invaluable in this, and we've learned a great deal about that role and how this can provide a great deal of support to families going through such a difficult time when they haven't been able to spend much time with their relatives during their last days. And I think that has shown how important that is, quick communication and discussion with the family. So I'll take the report as read. I think that the avenues we're working on is make sure we maintain the medical examiner role and the infrastructure we've got in place to do that, and also that we do need to get much quicker screening of the mortality cases to go through.
Thank you, David. And just a quick comment. I tend to put my head in and chat to the medical examiners. I think we've got a great team there. It's a new team.
Yeah.
They seem to be highly effective.
Yeah, I agree.
So I think Marcine had her hand up first, unless that's an old hand, Marcine. Okay, Jane.
Thank you. Just to say that the medical examiner came to the Quality Committee. She was very welcome, and she's been invited as a regular attendee if she would like to, so that we can learn from her work. And one of the things I think she spoke to the committee about quite very well is around communication and about the challenges with COVID, where families aren't able to speak to their loved ones. I don't really understand what's happening. And actually, she can sometimes be and is often the first point of contact to actually where they can actually have a debrief to understand exactly what's happened. And I think there's an initiative now to have some link people on the wards that will be appointed as the point of contact to help with families and to speak to them. And that's proving to be really effective. I think, David, isn't it? I don't know whether David or Andrea wants to talk about that, but I think one of the key issues that we heard from the mortality work was that it was about, you know, if people don't understand what's happened, it just makes their grief so much harder to deal with.
No, I agree, Jane. I mean, and I think it's not that this is a new issue. I think this has amplified the issue that's been going on for some time. And if you look through complaints or issues that the relatives have brought up for quite some time in the organisation, this communication on the care of what's happening on a day-to-day basis of the relatives on the ward is an issue, which, as I said, has been amplified by the difficulties in with COVID and visiting and being with the relatives. And places like ITU have put an enormous amount of effort into organising this so it happens in a routine way, and I think that means, you know, the relatives don't try and ring in. Someone knows, they know someone's going to ring them at a certain time. That's been the big, I think that's a big piece of learning, actually.
And is that happening on places like Aspen as well, David? Because not all deaths are happening on ITU, are they?
No, you're right, and that's what Jane was alluding to. That I think that is where Tanya brought up that, you know, some people who have struggled to find out about their relatives in the course of their illness when they can't visit has been incredibly distressing for them. And I think we have put in efforts in certain areas, but we need more to do. And you're quite right that it's not only those high acuity wards we hear about a lot. There's a lot of similar situations in people in other parts of the ward, and different wards as well.
Thank you, David. Andrea?
So I was just going to bring in, because Charlotte Broughton, who's our new head of patient experience and involvement, has really grasps this particular issue, and with her new appointed head of volunteers, they've been collectively looking at an improved way of being able to feedback to relatives on loved ones that are within our organisation across the board. So there's an improvement piece of work ongoing with that. It was just to highlight that we are addressing it. And another piece as well that we've done, a new initiative is for families to be able to send a message of love and support. It's like an e-card that goes through our patient experience team to the patient on the ward from a message from their loved ones. Again, it's just a new initiative, a nice touch that Charlotte's brought into play, actually, which has gone down very well. Good feedback on that.
Thank you, Andrea. Suzanne?
Thank you.
Thanks, David. I mean, I think in paragraph 5, the sort of detailed articulation and sort of review of the case of poor care is really powerful. I suppose powerfully promotes our main effort and the conversation we were having earlier about why it's so important. And I wonder if this particular case is a good, as tragic as it is, a good example of why we have these conversations with our teams. And I wonder if, Andrea, the work we're doing around the discharge piece, which is, you know, or continues to be a challenge. I mean, again, these sorts of examples of where we didn't get it right and the consequences, which, you know, are very sad, and where we could have done, you know, I think the evidence piece was a 50% avoidability. What a great, you know, way to use that story, I suppose, to make the point. So that would be my reflection on it, and that's where the learning comes and why this is such an important initiative, isn't it?
No, I agree, Suzanne.
Okay.
Yeah, I agree too. Absolutely.
Thank you for that. I think that was a very helpful discussion. And just to say for non-executives and any governors that are listening, a good way of taking the temperature of the organisation is listening into a shorts round. And Jane and I did that yesterday, and it was as usual, very moving, but particularly because it was around COVID, was particularly relevant. So to recommend it for those of you who are interested in that. So I'm going to move on then, and we're going to move on to emergency planning, resilience and response. So James. James on.
Thank you, Chair. Yep, I'm here. So thank you. This hopefully might clear one of our longest standing actions on the action tracker from October 19, that to bring that when this report comes back the following year, which we know are bringing it back. The difference this year on this report is just that it is very light touch. So this is part of our obligations under the Civil Contingencies Act, and my responsibilities as the accountable officer for emergency preparedness and resilience and response. So we're bringing this for the board to receive. It's not a formal assessment this year, but I'm sure everyone's read the report. It just brings out the key things that we were asked to do and assurance that we've done them. The key things there are about learning from wave one, and we'd already run a very comprehensive set of reflections after action reviews, culminating in presentations at two of our trust executive committees that we used for this, and onward feeding into our response for the second wave. And also in there is the training that we're doing around other things, that we're not just dealing with COVID. So the other things that we're doing around fire, power, cyber, IT, Brexit, all of the training tabletop exercises have all been carrying on throughout the COVID pandemic around those issues as well. So this report will go on, so it's been through our tech, it comes to here, and every year then we, Claire O'Brien, who's the emergency preparedness officer, and we present this to NHS England. But it's a far lighter touch. There's not the assessment there was last year. We have included the work plan that we did start the year with prior to COVID as well, but obviously a significant amount of time has been on the pandemic. I mean, what it does show, I think, is that we are normally our major incidents or our responses last, half a day, 24 hours, 48 hours. I mean, we've been running this one for 12 months, and in that we've had others that have been running parallel for half-day days within that as well. So it's taken us to a whole new level of our preparedness, our business continuity, and our resilience, and which overall will be a strength to the organisation. But this reflects the work that we've done this year and carrying on into the next financial year.
Okay, James. Yeah. I think that's fine. We're taking these as read anyway, so just ask for any urgent questions on this. Otherwise, we'll move on cognizant of time. Okay. Good report, I thought, James. Thank you.
Thank you.
And I know Claire behind the scenes is a force of nature. So I'm absolutely confident that she's got her hands all over this as well as yourself, of course. Thank you for that. I'm going to move on to the performance section, and this has been through both quality and modern healthcare that I'm aware of. Is there anything that either Jane or Merrick would like to add before I just ask James to give us an overview? No.
No, I don't have anything that we haven't already discussed.
Yeah, I think we've discussed.
Likewise.
This. Okay. James, so briefly.
Briefly, the assurance is there that prior to in December, COVID, we were very much on the incline in terms of the COVID curve. And it was sort of Christmas Eve where we were getting absolute instructions to stop non-urgent elective activity. And so this report was in a slightly different time. It was last month, but it feels a very different time. We were still commenting in this report about performance recovery trajectories. It provides assurance that we were onto that, and at the time we were ahead of where we were on schedule or ahead of that schedule, and that's good assurance. However, as we've discussed throughout the meeting today, those trajectories are old, they're out of date, and the completely new sets of trajectories will need to be drawn up once we come through this current wave. Just for reassurance, cancer continues to be done. So in terms of cancer activity, that remains unaffected. We've managed to continue that throughout.
Okay, thank you. David? You're muted, David.
It was an error, Andy. Sorry about that.
Okay, all right. No, I think this has been through committees. We've read the report. Anybody got any urgent questions on this one? Okay, thank you. Merrick, we've seen the Modern Healthcare Committee minutes. Anything you want to comment on that?
Yes, just to to say that obviously we've covered the main substance points throughout actually the whole of today's meeting, really around people and of course performance. So we won't cover that. But there's just two things. The electrical resilience we have approved. It's a long-standing risk that's been on risk register for many years. It's complex to solve, and it will take 3 years to solve. It's a long-term capital infrastructure project. So we carry risk as we look forward, albeit we've mitigated that risk where we can with additional temporary backup generators, but generators are not the only part of the whole risk equation. And then the other thing on the data center piece, just to note that in these more modern times, one would perhaps automatically assume that all of our data would be held in the cloud, i.e. on centralized servers in server farms. The cost of that solution over the 5 years would have been £6 million, as against a capital spend of 1.5 million and circa £18,000 per annum OPEX spend. So just really to note that that is the solution chosen. Otherwise, nothing else to comment on the papers.
Okay, and I think it's fair to say, Merrick, that is an interim solution for the cloud, and we will be moving to the cloud. But yes, at this moment, at this price point, it doesn't make any sense.
No, and I think as the papers said that effectively 4 to 5 years time, the solution we're putting in now becomes end of life. So obviously it'll be re-evaluated, but yeah.
Okay, thank you for that. Marcine, the people.
Thank you. Again, those minutes are old from November, and we have talked a lot about the people risk issues. I just want to raise 2 issues that came up in the meeting that we had last week. One is something as an exciting development, which is creating a new role called a patient companion. And this is an outstanding initiative, not only to introduce people new to the care system and into our community, but it's also a great role and opportunity for patients to get some companionship at a time where our nurses are incredibly stretched and busy. So I commend Louise and her team for the development of this role and for the success in recruiting to it. And what I think it also shows is that we are very serious about our anchor institution and making this role possibly showing them a career path, along with the cabin crew, as David mentioned, their skill set that we've seen in the vaccination could also move into our role. So very pleased and positive initiative that I wanted to share. And a more concerning issue that we have asked Louise and her team to look at. We had a report from the Freedom to Speak Up Guardian, and we continue to see a large increase in anonymous reporting. There is a lot of stress out there, and our staff are tired, but we need to make them feel that they have a trusted place to tell us of any issues. So I think Louise and her team are going to do more communication around that to try and get people to because we can't feed back, of course, if we don't actually know. The risks have been mentioned. I suppose just one last risk, which is because we have so many escalating areas and so much resource needed and continued requests for increased resources, we're using our own staff on bank. And the more you use your own staff, the more tired they get. So the whole well-being piece obviously is vital, which we've discussed. Those 3 points I thought were important to share with my board colleagues. Thank you.
Thank you, Marcine. Andrea?
Thanks, Andy. It was just on the back of Marcine's comment about the whistleblowing, the anonymous whistleblowing to CQC, and both David and I have sent communications out to the organisation just to reaffirm really the internal processes that we have available to staff to be able to air their concerns in a safe way, and in fact both David and our doors are open basically to individuals who want to come forward to speak to us, and in fact a couple have already, so that's really good. So it was just to say we have done something around that.
I read that, Andrea, and I thought that was excellent. Thank you.
Oh, thank you.
Thank you, and I added to that the staff governance should be on there as well.
Indeed.
I'm not sure your doors are open because you haven't got any doors.
Yeah, and you know what I mean.
And if we find out who's stolen them, we'll action that. I would just echo the patient companion. I had a good chat to them over in Ashford. They're very enthusiastic, really good quality people. So well done on the recruiting. I think you've been really good. And I think I saw 2 of them live in St Peter's yesterday. So I think they're now.
I hope they're all alive, but that's okay.
Yeah, I think they're all live, but 2 of them are live and on things. And also that just a word about the nurse apprentices as well. You know, when I bump into them, they are so up for it. They come up, they chat to you. They give you ideas, and I think again, it's a great initiative, and Lynn, who's been looking after them, has done a really good job, because they're not shy of coming forward, are they? Which is brilliant, and exactly what we want. And hopefully, people like them, will persuade people that they don't need to be anonymous to raise issues to the whole thing. Okay, so thank you for that, Marcin. So we now move on to Louise, the BAME system pledges.
Yeah, Chair, I'm not proposing to present this document. It's fairly straightforward. So really just to open for any questions in relation to what is a fairly short document, but just expressing our support to the pledges and some detail in terms of how, as an organisation, we do drive the EDI agenda.
Yeah, and I'm aware, I think that Dami and Aaron have joined that our BAME network. I wonder if either of them have got any kind of comments on this. Dami, Aaron?
Yeah, certainly Dami and I took an opportunity to talk last week and described a number of things that we'd like to do. I guess it's important just to note that at the moment our capacity to be able to do a huge amount is limited. However, we had a very positive conversation, and I know that, again, Suzanne and I talked about what we can do to make sure that we are planning a significant programme of work around the EDI agenda this year.
Okay, so let's take Aaron and then Dami.
Thanks, Andy. Hi, Louise. Yeah, no, I've read the document. It's great. I just wanted to ask a question about, there's a lot of information about quantitatively what the plan is and how it might go across and how it's measured and so on. Just wondering if any thought had been given to qualitatively how those things will be done, because I think a lot of the things that I've seen in other organisations just tend to focus about not necessarily what is done or what is achieved, but the method and the way in which people feel like it's done when it's been kind of activated. Just wonder if any thought has been given to that as well.
Yes, and I think sort of in tune with the conversation that Dami and I had, really, which is about making sure that we are involving people in the planning of this and actually in the execution as well, and using people's ideas in order to make sure that we are applying the kind of focus in the right place. So I think it needs a level of detail in order to demonstrate that, and I'd hope that we'd be in a position to share that with colleagues soon.
Okay, thank you. And Dami?
Yeah, I was just going to echo that really, and just say, yeah, I think it would be useful to have a bit more detail. And as we said, how we tangibly demonstrate the equity and the inclusion, how we measure what we're doing and how we show that we're doing these things. But yeah, thank you.
Thank you. And just to say, by the way, the fact that you've joined that forum, I've had some really good feedback from people in that forum, colleagues who've said that they really appreciate the fact that we've now got non-executives in that forum. So that's really good news. Okay, thank you. Thank you, Louise, for that. We'll move on rapidly to the SAL, the annual report and accounts timetable. Still there?
Thank you. Yes, sorry. Yeah. Thank you, Andy. So the timetable is for noting. The caveat is that there will be more detail to follow, but it looks very much in line with the NHSEI ambition to again lessen the burden this year, that we are following a similar timescale to last year, which is a slightly later submission of our annual report. And again, the quality account is not required to be included in the annual report. So we're very much mirroring last year's timetable, but should there be any further detail shared with us, we'll obviously update the board in due course.
Okay, Simon and then Keith.
I was just smiling at the lessen the burden comment. The auditors get 2 weeks extra. The finance team is expected to work through a weekend at the end of April, in addition to the quarter 1 planning regime, which will also be in that quarter as well. So it was, yeah, it would be more helpful if the finance teams could have a little bit more time in that initial period. But this is the statutory guideline, so we're stuck with it.
Okay, and Keith, before I bring you in, just I hope you're going to cover the fact that how we avoid the issue we had with stock in the last audit. Keith.
Thank you, Chair. So we had our Audit and Risk Committee last week, and in addition to what Sal was saying, we recognised actually that the currently proposed submission deadline for the annual accounts is mid-June rather than the end of June, that was relaxed this from the previous year. So we will actually have to bring our Audit and Risk Committee dates forward, and similarly the extraordinary board meeting that we have to sign off the accounts. So there is some work to be done on the diary, which will affect us all. Secondly, we had a robust conversation with our external auditor around the necessity to have again, I'm using the same word, robust plan for a stock account, and then gaining this sufficient assurance. And there's a commitment that they'll bring back their work proposals prior to our next Audit and Risk Committee meeting on the 18th of March. Okay. So we're engaging with them quite closely, and we're taking full advantage of the additional guidance that's been issued by the Institute of Chartered Accountants and others.
Okay, good. I was aware obviously that there was another issue that we've seemed to have headed off at the pass, but let's keep an eye on that. Yeah. Okay, thank you. Okay, Sal, you've got the changes in hand, I guess, to the timetable in due course. Yeah, fine. So going to move to the use of the trust seal. I think we've read that. Simon, anything you want to draw our attention to?
Not really. It's relatively standard. Obviously, we've taken on the lease of an extra piece of land at Tesco's in Ashford just to help out the staffing. You might be interested in why we've hired a bowling pavilion, which is in support of our community midwifery out in the community. So it's again a short-term lease, but slightly unusual in terms of its location. That one.
Yes. Yeah. Okay. Thank you.
Thank you.
Somebody got the hand. Oh, Keith, is your hand up still up, or is okay? Yep. Thank you for that. Noted. And the trust schedule of business, I'll take as read. This is Sal and her team on a shoehorning. Of course, we have gone down to 6 meetings a year, which does mean that we get very full agendas. But I think you've shoehorned it in well, Dami.
Sorry, just on that schedule, just clarifying that the dates for the quality of care and the committee and modern healthcare have been changed to the 1st of April. It says March moved to 1st of April.
So that's the board meeting.
Board has moved to the 1st of April to enable quality of care and modern healthcare to move to 1 week later. Yes, exactly. Yes. Okay. So if those appointments haven't followed, they will shortly.
Thank you.
Okay, I think we've got a number of hands up. Let me just, I think Chris, yours was next.
Thank you. Very helpful this actually, Sal. Really good to get that overview. Just on the Integrated Digital Committee, there's one on the 4th of February. I'm not sure that's been noted on it. Okay, yeah, thank you. And it's in our diaries as well, of course. Thank you for that. Jane, and thank you.
And it's actually, I've just had a quick look through. It's not really that relevant to the Quality Committee, but I was just checking where we are due annual reports and given our light touch on governance, it's just some guidance on that really, because obviously we have a schedule where we regularly receive certain reports throughout the committee, so we just need to consider that a bit.
Yeah, I think that's right. We'll take that away. I mean, but I think today's approach has kind of worked in terms of, and I think I would just carry on with that approach, given that, we're all highly intelligent people that can read, and then we bring urgent questions back.
Okay.
And actually, doing the work in committees as much as we can. So I think, Keith.
I was hoping that the move of the board back to the 1st of April would have given an opportunity for a longer period of time between committee meetings and then the board, so that actually a report could come through. But although I've kept the audit and risk on the 18th of March, the other committees have been put back a week as well as the board, and I'm not sure of the benefit of doing that, because if we had a fortnight gap, there would actually be time for written reports to come through.
I suspect it's because of when the data's available, but is that right, Louise? It's when the data's available is the issue.
So whether as a board now we are meeting every other month, there's that longer gap, whether we can work towards a position where normally, rather than simply the week before the board, but instead a fortnight before the board, we can have most of our committees. That I think will allow a smoother flow through of information, and save this looking back 2 months business when we have all the minutes.
We'll take that away. I think Sal will take that away and have a look at it. It's a absolutely reasonable request. It would mean us moving board meetings, I suspect. But let's have a look at that. Sal, do you want to say anything, or is that?
Yeah, I mean, the tension is always around the production of the data to enable people writing reports for the subcommittees an adequate amount of time to interpret that data and provide the necessary analysis, which does mean that it pushes those subcommittees to the week before board, and that's literally just the turnaround time on the information. We can look at it again. I'm happy to take it away.
Okay, I wouldn't want to make a big deal of it, and I certainly perhaps wouldn't want to be pushing the board into the following month, because I think having it just before the end of a month seems to work well for NHS business, in terms of Surrey Heartlands and nationally, because they like to get things signed off by the end of a month.
Okay, thank you. Chris?
Sorry, I forgot to mention, is there something that exists in the system in terms of all the other meetings that we have to attend, and I just wonder whether it would be worth getting those on our radar as well, or would that just get too complicated?
I think that might be quite complicated. I mean, if you just put the system meetings that I'm on in there, that would just horrendously complicate it. I think we could certainly put the quarterly NED meetings in, Chris, because that is relevant to a lot of
and maybe some key ones like your chair meeting, maybe. I mean, I know Surrey Safe Care is something that takes up my time. I'm sure other colleagues have other issues.
There's just such a lot of them. Is my
well, that's the issue, isn't it? But we all have other committees, then we can't. That's going to impact on our own business.
And indeed, we've just had a GGI review of the ICS governance. And certainly I was pushing yesterday in terms of that to say, how are we reducing bureaucracy, but and meetings, but it's not immediately obvious from that report, I have to say. Keith?
You mentioned then quarterly NED meetings. I think if you mean the NED and governor meetings, they're supposed to be every 6 months.
I don't. I mean the Surrey Heartlands quarterly NED meetings.
Thank you. Thanks.
Okay. We could certainly put the governor meetings in there then. Right, I'm going to move on now to any other business. I haven't had any notified. Is there anything else anybody wishes to raise? No, okay. questions from the public. Liz, do you want to read out that question we've had from Rosemary, I think?
Okay. So the questions from Rosemary, who are the named people in Ashford and St Peter's hospitals responsible for the interface with mental health inpatient and outpatient services?
Let me just, I think we've answered this one.
Yes.
Because we've absolutely comprehensively answered this one. You know, it depends on the clinician who's on duty. It depends, you know, ultimately, obviously, David, but I think we've answered that last time, actually, that one.
And
So,
the second question, why has the plan to accommodate the psychiatric liaison service in the upgrade of the St Peter's Hospital been dropped?
So I spoke with David and Andrea yesterday. It hasn't been dropped, our point of view. We would wish, once our new A&E and assessment facilities are in place, to have the psychiatric liaison team in with us as integrated. We are not aware. We certainly have not dropped that. Obviously, Surrey and Borders have to agree that they will come over. And I think, David, you can probably talk to Justin about that, can't you?
Well, in fact, we've recently had a meeting with Justin and his team. So we are actively discussing this, because this is a plan to work together.
Exactly. So the answer to the question is, it hasn't been dropped. It's actively on the table, and we would absolutely, as a board, wish for that team to work with us. And it doesn't make any sense from my perspective to have them sitting in Abraham Cowley when we've got the room and the space for them in the new build. Suzanne, did you have your hand up?
But it's only really to say that only yesterday I was speaking to Graham Wareham about exactly that point. So, but David's obviously, you know, also, so active conversations are absolutely ongoing, as you say.
Okay, so I think that's answered the question, and obviously when we have the final sign off of the A&E and who goes where, we will report back. Okay, so that was our questions. There were no other questions from the public, were there, Liz? Okay, I'll take that as no. Reflection, has this format worked for I think, you know, we have taken an hour off the board meeting time, so which I think is good. I think we've had a good comprehensive look at the risks, and I think that report, albeit a work in progress, was actually hugely valuable. Suzanne and Sal, thank you for your hard work on that. Any other reflections, Jane?
My only reflection is that some of the time we take is because we have a story, and hearing the voice of people having the experience, we're kind of missing that.
Yes.
But I think maybe it is necessary at the moment, but I just don't want to lose sight that it really gives us a sense of what it's like to be, to experience a service. So we haven't had that.
No, and there is absolutely no intention post this period of intense work to drop that. It is so valuable to have both staff stories and patient stories. We will absolutely reinstate those as soon as we can.
Okay, so, excellent.
Good point, Jane. Thank you. Any others? Suzanne, does this work for the exec side, do you think?
I'm looking to my execs. I wouldn't dare to, but from my point of view, I think it's been absolutely fine and very helpful. And I'm looking, they're nodding and smiling. So yeah, I think it's always good for, I mean, from my personal point of view, we are literally running full pelt, and of course, for us, this does give us an opportunity. And even when we have the executive meetings, they're normally very compressed at the moment, many things to get through. So in a way, you're sort of inadvertently providing us with a little bit of opportunity to take not stop, but take a breath, be more maybe considered, spend some time as a board, and and to have the kind of objectivity that you guys bring in terms of your questions and observations, I think is really helpful. And I think it's it's not just good for the organisation's governance, it's actually quite good for the team. I think that would be my feeling.
Okay, I'm going to ask Andrew Wilson, as our board advisor, who's sat quietly and watched all this. How did that seem for you today? A different format? Assuming Andrew's still there.
Is that better? Sorry, something.
Yes.
Yeah. I know. I thought it was a good meeting, Andy, and I thought all the communication was well and clear from where I was sitting, and I agree with what Suzanne's just said, because one's just conscious of the pressures on people and the system at the moment, and have times where people can talk to each other like this and get into some of the detail, but be aware of the realities is important. And so no, it felt, given what we're all facing here, like a very good conversation to me.
Thank you. Well, I'd like to thank everybody for their time and their application in reading through the 355 pages that I noted. So that, and also, going back to what we said at the beginning, sincere thanks to you, our executive colleagues, for all the fantastic work you're doing with the team, and to keep the team together and keep them motivated, which is a huge task at the moment, absolutely huge task. But thank you for all you're doing. And thank you to those members of the public who've joined us today, I think mainly governors. Hope you found that useful as well. Thank you very much, everybody.
Thank you, Andy. Thank you, colleagues. Thank you.
Bye.
Thank you very much.
Thanks, everyone.
Good. Thank you. Very good.